Hi, I'm Beth Battolino, CEO of Healthy Women. Thank you for joining us today on Healthy Women's first talk show, WomenTalk. Hello, and welcome to WomenTalk. I'm Beth Battolino, CEO of Healthy Women and your host of WomenTalk. I am super excited to bring you a two-part series on gynecologic cancers, specifically cervical, endometrial, and ovarian cancer. In our first episode of our series, we're going to find out what a gynecologic oncologist is and when you should see one, with the help of Dr. Amanda Nichols Fader, a professor in the Johns Hopkins Hospital Department of Gynecology and Obstetrics and the Sidney Kimmel Cancer Center. We're going to learn about the symptoms, the testing, and treatment options available for women who have been diagnosed with gynecologic cancers. But we're also going to talk a bit about preventing cancers too. So stay tuned. Dr. Fader is the Vice Chair of Gynecologic Surgical Operations, the Director of the Center for Rare Gynecologic Cancers, and the 2024-2025 President of the Society of Gynecologic Oncology. Okay, Dr. Fader, you are a busy, busy woman and doing such important work. Thank you so much for taking time out of your busy schedule to join us on WomenTalk today.
Thank you so much for having me, Beth, and please call me Amanda.
I am going to call you Amanda. But so Amanda, I want to first start off, why did you become a gynecologic oncologist?
So when I was in college, my mother was diagnosed with cancer, and I became really intellectually and emotionally invested in learning everything I could about cancer. And when I decided after that, that was one of the most formative events in my life. And I decided I definitely wanted to go to medical school, and I wanted to take care of women with cancer, and was trying to find that perfect specialty that would allow me to do that. And gynecologic oncology is a specialty where physicians help prevent, diagnose, and treat patients who have the below the belt women's cancers, the female reproductive tract cancers. And I initially thought I was going to be a medical oncologist and treat just the medical aspects of cancer with things like chemotherapy. But when I rotated on my OBGYN block and did specifically a gynecologic oncology rotation, it was the perfect intersection of women's health, oncology, and surgery. And so a GYN oncologist is first and foremost a surgical oncologist, but we're the only surgical oncologists that also provide the medical oncology care to our patients as well. So the chemotherapy, the palliative care, the quality of life care, menopausal care. And so it's a really holistic field that allows us to have great continuity with our patients over many years and take care of them as a whole woman.
I can see why you gravitated to that, because when you talk about that and all the kind of the touchstones that you have throughout a woman's life, it is the continuum of care. Sorry, I couldn't say that word. So let me ask you, when should a woman consider seeing a gynecologic oncologist?
Well, so our specialty as GYN oncologist is in the 5 female reproductive cancers. So ovarian, as you said, uterine or endometrial, cervix, and then vagina and vulvar cancers. And so if a woman has been diagnosed with any of these cancers, or there's a suspicion of such a cancer, or she is at high risk for one of these cancers due to a genetic or family history, those are all really compelling reasons to come see a specialist. And the reason for that is we have many years of specialty training and additional years of experience focused just on patients who and people who have these types of problems. And we know from the medical literature, from research reports, that survival rates and outcomes are actually better in these settings when you have one of these diagnoses, when you see a GYN oncologist compared to a more general specialist, like a general GYN or a general surgeon, for example. And it's because, again, we have that specialty training in surgery for these cancers or precancers, the medical experience about what's life like after cancer. And we can also offer really specialized treatments like clinical trials and state-of-the-art therapies for our patients.
And how many, like, so access to someone that's in your specialty, to a gynecologic oncologist, I wouldn't say that there, how many are practice, like, do you have that stat right now? How many people are practicing and how hard is it? Because I think of women in the Midwest and some of the desert areas, and would they have access to a gynecologic oncologist?
It's a really wonderful question. My guesstimate right now is that there's about 1,300 to 1,500 GYN oncologists in the country. So not that many. However, I actually do a lot of research in the geographic distribution of oncology specialists across the country. And we did do a study to see what that distribution looks like. And we do need to improve that because you're absolutely right. In some rural areas, it's difficult to find cancer specialists in some settings. But what's really nice is that many hospital systems, like my hospital in Baltimore at Johns Hopkins, we have sort of a hub and spokes model type of
Yeah.
approach to care where we really partner with other institutions and clinics and hospitals across our state and across multiple states to ensure that we can be there as a resource for our patients and providers in those areas. But there are many GYN oncologists in suburban and in some rural areas. About 15% of GYN oncologists are in at least do some rural care as well. And telemedicine, that was one of the, possibly one of the good things that came out of the pandemic that allows us to provide care to patients when they're not right in front of us in the clinic, really opened up access to many more patients for us. And it also increased satisfaction for patients so that even if they could get to the hospital or lived right around the corner, how nice is it that not every visit has to be in person? Where a patient who's undergoing treatment, for example, is not feeling well, can do it from their own home, for example. So I think a lot of modern innovations in medicine, including telehealth services, have allowed us to really provide better care for patients in rural and underserved areas.
I'm so glad to hear that. And because I always like to hear or tease out what's positive. And during COVID, that was, no pun intended, COVID positive, right? Like that was a positive advancement. And
Yes,
now we need to continue fighting the fight to make sure that our insurances cover the
that's
telehealth.
exactly
Yeah.
right. And
Yeah.
a big advocacy issue for us at the SGO on Capitol Hill, for
Yep.
sure.
And same with Healthy Women. So
That's
if we can
great.
help you fight the fight,
Let's do it
we
together.
would love to partner. Yep. So let's talk about some of the more common types of gynecologic cancers. What are you seeing right now?
Yeah, so the most common type of gynecologic cancer in the United States is actually endometrial, otherwise known as uterine or womb cancer, cancer of the womb. And this can be diagnosed in almost 70,000 women a year. And one of the concerns with endometrial cancer, and I'm going to talk about the good, the bad, and what we're working on to provide hope and better outcomes for women today, is that endometrial cancer is actually directly associated with being overweight or obesity. And it is the most obesity associated cancer in men or women. And so, as we've seen a rise in the obesity epidemic in the United States and many countries around the world, so too have we seen a rise in the obesity related cancers. And while most cancers are plateauing or decreasing in incidence, endometrial cancer is one of the only malignancies that's rising in both incidence and death rates. And so, this is an area I really study quite closely, and I have a lot of hopeful messaging around that today. And I know we're going to talk about this a little bit later, but it is a preventable cancer, but one we really need to get a hold of because it's the fourth most common cancer in women right now in the United States. However, by 2032, it's going to overtake colon cancer as the third leading cause of cancer in women. So it's really, really important for all women to know about this cancer and about how to recognize the symptoms and how to prevent it. Cervical cancer is another common cancer, although much less common in the US because of the advent of the Pap smear, human papillomavirus or HPV testing, and HPV vaccinations. And we'll talk about prevention again a little later. But before the advent of the Pap smear in the 1940s, 1950s, cervical cancer was one of the leading causes of cancer incidence and death in women, and it still is in some parts of the world. But in industrialized nations that have Pap smear screening and HPV testing, and HPV, by the way, is the most common cause of cervical cancer, is a sexually transmitted infection. And it's the most common sexually transmitted infection in the world in men and women, and it's prevalent everywhere. And I want to sort of demystify that because any one of us could have been exposed to HPV, even if we've, been in completely monogamous relationships. It is that prevalent. And so many of the HPV types do not cause cancer, but there are a few that do and can cause cervix cancer, also vagina and vulvar cancers, and cancers of the throat, the anus, and in men, penile cancers as well. So it's a really prevalent problem as well. But in women, the pap smear has really helped us reduce cervical cancer rates because we've been able to detect precancers earlier, treat those, and prevent, which is great. And then the final cancer is ovarian cancer, which is the second most common cancer in the United States. One of the latest advances that we know of in ovarian cancer is actually most ovarian cancers don't start in the ovary. It's a misnomer. They start in the organs that are right next to the ovary, the fallopian tubes that help women carry their little eggs when they were released from the ovary into the uterus for potential fertilization and pregnancy. And so 90% we think of ovarian cancers that we know of are now starting in the fallopian tube and then spread to the ovary. This can be a pretty lethal cancer and is often diagnosed in more advanced stages, but we've had a lot of great advances in treatments and prevention measures for this cancer and all three of these malignancies.
Do you want to start talking about prevention, or I can follow my script and ask you? We can talk about the screening test or diagnostic test for these three cancers, and then we can talk a little bit more about. I'll weave in the prevention piece.
Absolutely.
Yeah.
Whatever you.
Yep, I'm going to go with the screening. I'm going to follow my script, and we'll go with screening test or diagnostic test for these three cancers. So let's start with cervical cancer, and we talked a little bit about it, the screening test. But if there's anything else you want to add to that.
Yeah, so the pap smear combined with the HPV co-test. So when you go for a pap smear for your annual visit, you're not just getting a little spatula that's gently taking cells off of the surface of the cervix during a speculum exam. You're also getting what's called, in many cases, an HPV co-test, which is testing for HPV DNA or the genetic material in the HPV virus. And with the two together, this is quite possibly to date the single most effective cancer screening test in history. That's probably going to change in the future as more sophisticated molecular platforms are being developed for cancer screening. But again, this has reduced the rate of cervical cancers in the United States by over 80%, actually, and in many countries around the world. So ladies, get your annual exams. This is a life-saving cancer screening test. Your annual visits can be life-saving and also really helpful for your quality of life and just how to live your best and most healthy lives. So that's the story about screening in this field, because there is no screening or test for endometrial or ovarian cancer. And I'm in my research at Johns Hopkins, I'm working with a multidisciplinary team where we're working on development of a screening test for endometrial cancer. But we do have a diagnostic test, and that's because with endometrial cancer, fortunately, there's a symptom associated with most endometrial cancers, and that's irregular bleeding or spotting. And in postmenopausal women, so women who've gone through the change of life, you shouldn't have any bleeding after you've gone through perimenopause and that sort of thing. So if you're 56, 57, and you suddenly have some brown discharge or bleeding, that is never normal, and you should go to your friendly neighborhood gynecologist or your internist or whoever you trust to do your pelvic examinations and get that checked out, because that could be a sign of a precancer or cancer. Now, bleeding isn't always cancer. It's only cancer in 30% of the time, but that's pretty high and it's always abnormal. And so that's one of my go-to messages today for our listeners. But we use a test called an endometrial biopsy, which is it's like a tiny little straw that we use that we insert through the cervix to take a little piece of tissue when we're concerned about that. And we also use ultrasound to look at the inside of the uterus and see if it looks abnormal. Unfortunately, for ovarian cancer, there is no effective screening test that has been identified for the general population. And diagnosis often involves relying on a combination of pelvic exam and imaging studies, such like as an ultrasound or a CT scan, and blood tests. Right. We have a blood marker called CA125 that stands for cancer antigen 125, which is a protein on the outside of the ovarian cancer cells that we can use, but they're not a good screening test for low-risk women. It's been studied across multiple clinical trials in women who don't have a known risk for higher risk for ovarian cancer than anyone else. in the general population and has not found to be effective in terms of improving or saving more lives, if you will. But that work is still ongoing, and the symptoms of ovarian cancer that are really important to sort of pay attention to can be puzzling because they can mimic other just general women's conditions like bloating, for example. Like, which woman doesn't have bloating
Right.
at some point, right? And especially in peri and postmenopausal women. And so it's really a bloating or abdominal discomfort that lasts more than a week to 2 weeks. It's just not going away. It's not associated with eating or any other position. If there's a major change in your bowel or bladder habits, like you're suddenly not going to the bathroom as often, or your stools are more narrow, or just something seems off, or you get full more quickly with eating smaller meals, those could all be signs. And if you have any of those symptoms and they persist, again, would absolutely present to your gynecologist or internist or primary care provider.
So those are so important. So the endometrial cancer symptoms could be, if you're postmenopausal and you have some bloody discharge, that would be a reason to make sure that you go and see your gynecologist.
Absolutely.
And if for ovarian, while a lot of the symptoms can be dismissed, if you see a change in stool pattern, if you feel bloating that does not go away within a week, it's just something that you should make an appointment and talk to your healthcare provider, your gynecologist about.
Absolutely.
Yeah,
And sometimes, again, we're not perfect as physicians and
no one
providers
is.
either. And so
No one is.
it's really important to advocate for yourself when you're having persistent symptoms. And so brown discharge or spotting or bleeding of any volume in postmenopause, abnormal. I didn't mention that, and equally important, this can happen in premenopausal women too, which can be
Yeah,
a little more difficult to discern because you might be having monthly cycles. And so
right.
how this might manifest in a premenopausal woman is you have longer heavy periods than normal, or you're spotting between periods, or just always bleeding a little bit, and or the discharge is more abnormal. And so any sign of this, it's just my cycle is off, this just doesn't feel right. If you feel something, say something and go to your doctor and make sure that that you feel heard.
I love that. I love that. That's such good advice. And I know for so many of us, we're so dismissive and just say, "Oh, it's nothing. Oh, it's nothing." But taking that time and making that appointment and taking
Right.
care of yourself is so important. So
Yes.
genetic testing, I want to talk a
Yeah.
little bit about genetic testing when it comes to gynecologic cancers. What role does that play?
A really important role. And so, one of the best ways in terms of prevention of gynecologic cancer or really keeping up with your health is knowing your family history, if possible, and knowing what you're susceptible to, because knowledge is power. With that knowledge, that can be a huge prevention tool that can be utilized between patient and provider. And so, up to 10 to 25% of gynecologic cancers will be inheritable or hereditary. And so that means that either a gene was inherited from your mother or your father and passed down to you, and it puts you at increased risk for a particular type of cancer or several cancers. And so there's syndromes like mutations such as the BRCA1 and 2 genes. For example, BRCA stands for breast cancer gene, but what what is equally important with the breast cancer syndromes is that ovarian and fallopian tube and sometimes uterine cancers are risks there. And so, for example, the BRCA1 gene mutation carriers can have a risk of up to 40%, lifetime risk of 40% of fallopian tube or ovarian cancer, and a smaller risk of uterine cancer. Whereas the BRCA2 patients may have a risk of, or carriers, excuse me, may have a risk of up to 25% for ovarian cancer. So very, very high. And so kind of knowing that can really help a woman as I love what you said earlier, taking care of women throughout the continuity or continuum of their care. We do a lot of reproductive based care. Like some patients are diagnosed with these precancers or cancers at a reproductive age or even as teenagers. And it's devastating, right? But
Yeah.
we have a lot of hope there because there are fertility sparing treatments in several cases. There's opportunities for patients to freeze their eggs if they're going to have a
Yes.
chemotherapy treatment, for example, or just not take everything out in terms of all their pelvic organs, but be more judicious about it. And so knowing a woman's genetic history can allow us to start keeping a closer eye on her earlier, well before, years before the cancers might develop, so that we can help them with their life goals, their reproductive goals. And then in this case, when we know a patient has a risk for cancer, and there's many other genetic syndromes too. There's genetic syndromes that increase your risk of uterine cancers and endometrial and cervical cancers as well. So knowing that is very powerful, because then you have a specialist keeping a really close eye on you, and then we can help plan a prevention strategy. How do we help you have a long and fruitful life and still achieve your goals? And sometimes that involves prophylactically removing some of those organs in order to achieve that.
So you said a couple things that I absolutely love, because you're taking care, you're looking at prevention, we're looking at genetic predisposition, and there's so much hope right now because there has been so many advancements in this area, which is awesome. And I feel like sometimes we're so
Right.
pessimistic instead of being optimistic. And I have seen
Okay.
the changes, and I love the fact that you've touched on many of them. So one question I have for you, because I'm putting on my nursing hat right now, and it's, that patient that comes into the office that may have a family history, and she's going to her primary GYN. Should she really be seeing a gynecologic oncologist, or asked to, how does that referral happen? Because I do think someone that may have a higher
Right.
predisposal for some type of reproductive cancer may want to see a gynecologic oncologist sooner than later.
I think that's a great point. And I am so fortunate to work with so many talented primary care providers, right? They are the heart and soul of medical
Yeah.
professionals and the gatekeepers of health. And I really love partnering with primary care providers in this kind of care. And so sometimes that means, they make a referral to me and they're like, please, can you just take care of this situation, or care for this patient over time? And sometimes it means that I just provide a consult and guidance, and or that we share the patient and the patient sees both of us over time. I'm really excited to do that kind of care. Preventive oncology is the best oncology, right?
Yes.
Right. And
Yes.
so even though I'm a specialist for women with these cancers, my best days are when I can help prevent a woman from developing one of these cancers and maybe be put out of business one day through advances in the field. So we're usually very flexible as GYN oncologists in working with partners. But I think from a patient standpoint, you need to know that we exist as specialists, and it's okay. It's more than okay. You should advocate for yourself. No one's going to advocate better for you than you. And so if you have a concern about a family history and you're getting blown off, or maybe not taking as seriously as you'd like to be, you don't have to settle. You can see another provider. You can ask to see a specialist. But most primary care providers are pretty savvy about this and will, refer for genetics counseling or to a GYN oncologist to get more information that will help guide risk-based treatment and assessments.
I think that's great. And you're absolutely right when you say primary care, right? Because not every woman is going to a GYN or has access to an obstetric gynecologist. So your primary care can also do the referral to an oncologist, gynecologist as well. So thank you for bringing that up. And I think that's the role of Healthy Women, is to raise awareness about, different types of cancers, but more importantly, what you can do and who you can see and what these specialists are, and the added value you all bring to women's lives. So thank you for a great answer to those questions. And now I want to talk a little bit about treatments for cancers.
Yeah.
Are you seeing advancements? What type of, treatments are you seeing right now? Is there any standard of care? So if we could talk about, like cervical dysplasia,
Yeah.
does everything have to be surgical, or is there other treatment options now that are being used or in partnership with?
It's a wonderful question. So cervical dysplasia, as many listeners may know, is a precancer of the cervix. It's almost always HPV related as well. And when we diagnose a cervical dysplasia, it's a great opportunity for us to intervene and prevent cancer, which is a great day, right? But it can result in costly, and uncomfortable treatments that a woman has to go through. So just because it's a precancer doesn't mean it's not, a woman doesn't suffer or doesn't, have to go through an invasive intervention. And one of the treatments for dysplasia is a minor surgery called a LEAP procedure, where we just anesthetize the cervix so the patient doesn't feel anything, and then gently remove like the outer surface of the cervix where the abnormal cells are with a little electric. It's like a little half moon shaped little hot wire. And many times we can cure the dysplasia with that approach, but sometimes it's not cured, and other treatments are needed. There's some types of dysplasia. One of them is called CIN1, which is not precancerous and doesn't need treatment. It just needs close follow-up. But the CIN2 and 3, which are the little more aggressive forms of cervical dysplasia, do require some form of treatment. And the standard of care really is surgical to remove those cells. There are other treatments being studied right now, medical treatments that can be used as standard or alternative standards, I should say, or being tested in clinical trials. But if a woman has severe dysplasia and has already had a LEAP procedure, sometimes it requires a more invasive approach, like a hysterectomy, to really remove all of the abnormal cells. So I think I answered the dysplasia question
You
for you.
did.
Okay.
Immunotherapy.
One of the most exciting
Yeah.
and transformative treatments right now in cancer medicine. You may recall President Jimmy Carter had widely metastatic melanoma like 6 years ago, which is almost always, before the advent of immunotherapy, synonymous with death,
Right.
unfortunately. But immunotherapy are a new class of drugs. They're not that really are designed to target and sort of wake up your immune system, or the helper T cells that help attack and recognize cells as bad, if you will, or foreign, and really help undo the substances that the tumor releases into its environment to help sort of put the immune system to sleep. So it's like nothing to see here, folks. I kind of liken it to, I don't know if there's any Star Trek fans out there. I'm a Star Trek nerd, but I don't know if y'all remember, the Romulans were one of the enemies of Captain Kirk and
Yes.
the Starship Enterprise, and they had this cloaking device on their ship. And it was always like the episode was like Spock and Kirk, and they're looking out into the galaxy, and all of a sudden it's like, oh, the Romulans are there. And the ship would uncloak itself right as it was starting to fire. And that's actually what tumors do. They cloak themselves in these inhibitory substances so that the immune system of the patient or host doesn't recognize them as bad. And the immunotherapies kind of inhibit that inhibitory substance that the tumors release so that they can't mask themselves. This is very simplistic. It's much more, people much smarter than me develop these therapies, but they really open up and wake up that immune system. And they can be used alone or in concert with other immune therapies or with chemo and radiation. And we're using them primarily in endometrial and cervical cancer right now, where we've seen tremendous revolutionary changes. I've been very fortunate to be on help co-lead or be a part of some of the clinical trials that have defined these standards of care in these diseases. But we're really excited about the immunotherapy era and what that's bringing for patients. And President Jimmy Carter is, I think he's on hospice now, but lived, I think, another 6 or 7 years because of these types of therapies. So
No, it was amazing to watch his journey and seeing some of the great advances in care, and the immunotherapy is right up there.
yeah,
And surgery too. Like we're seeing
yeah,
such a great shift with surgery going from traditional. And when you mentioned hysterectomy a couple times during our conversation, and now we can see with robotic surgery now the downtime
yes,
for women. So the improvement and minimizing um, procedures too, right?
yes,
And you can talk more into that, but I'm just from my nursing, I'm taking care of the patients after they've had surgery, and there's just been such a dramatic improvement with how
absolutely.
different procedures, right? So
That's
can you
an
share a little?
Right. Yeah, so the minimally invasive surgery era is also here.
Oh,
And over the last 20 years, we've increasingly used it to treat women with benign and cancerous conditions of the gynecology tract. So the vast majority of hysterectomy now should be, and mostly are, performed through small dime-sized incisions instead of painful up and down or bikini cut incisions. This is not your grandma's hysterectomy, right?
yeah.
And so women are going home the same day in some cases from these surgeries. Sometimes they stay overnight. But yeah, you mentioned it, less blood loss, fewer complications, less pain medicine, getting back to work faster, and just recovery is just so much nicer for patients. And it's especially nice for patients with precancer or cancer because they're already dealing psychologically and physically with so much with these diagnoses, that to be able to offer them a treatment that's minimizes the stress on their bodies and gets them back to themselves or ready sooner for the next phase of their treatments, I think has been really, really nice. So
And then chemotherapy. Have you seen a change in chemotherapy? Because I think, when we originally started with chemotherapy, it was almost like, thank God you survived chemotherapy, right? Because the chemotherapy agents that they use is in the dosage could potentially kill you, right? So we've seen the involvement of chemotherapy. How is it today?
yeah, so we're still using some of those old school drugs, the cytotoxic agents, because they work.
Right.
But we're learning how to better temper the side effects. And
Mhm.
there's a slew of new, what we call biological agents, targeted agents that really are helping us realize the promise of what we call precision medicine or personalized oncology care. And that is to really study a patient's tumor instead of like giving a treatment that let's say a patient has a cancer come back and is, before we would be like, oh, I'm going to try this and see if it works, right? And it's kind of an empirical choice, well, based on some data, but we never really know in a specific patient that a therapy is definitely going to work for her. And
Mhm.
so by testing a tumor's molecular profile, and that, by what I mean by that is looking at the proteins and the DNA, the genetic makeup of the tumor, and whether it has any aberrations or mutations there that we can actually target with drugs. And if we can target a mutation with drug, it's called an actionable mutation.
Mhm.
And so, there's been just an explosion of incredible new therapies that really have allowed us to extend survival for many years for patients with cancers. That when I started as a fellow and as a new physician and practicing, like, we had very few treatment options for some of these patients. And to be able to personalize it, we know that personalized medicine and seeing a specialist like a oncologist are like a perfect like recipe for, giving a patient the best possible outcome.
I love that because that Healthy Women, we say one size never fit all. Like, how
Yes,
they came out
exactly.
like, oh, one size fits all. We're like, no, no, it really doesn't. If you're a woman, one size
That's
does
right.
not fit all. So I loved
Yeah.
hearing, seeing the progression to and treatment options because you're taking that individual into mind and really customizing their treatment plan. So I love that. And then radiation, is that still a big component of kind of the care plan now too?
It certainly is a component, and especially if we don't use it much for ovarian cancer, but we do use it in select endometrial and ovarian cancer settings. And yeah, so it's an important component. I would say that, and forgive me for the radiation oncologists out there, the advances in radiation therapy have not eclipsed those of, say, what's happening in the chemotherapy or the molecularly targeted
Yep.
era. However, it's still a very, very important part of treatment. Um, if we can get to a point though where we can personalize things so much that we can do what's called de-escalation therapy, because right now, and sometimes in cancer medicine, we're like throwing just all kinds of things together, and it's very aggressive treatment, but it's incredibly toxic, as you said, and that remains true today. And so we might cure a cancer, but a woman may have a lifetime of chronic, toxicities like numbness and tingling in her fingers, neuropathy, and sexual, sexual health issues and vaginal atrophy, and just all kinds of those kinds of concerns. And so the more we can de-escalate chemo and radiation and look to more targeted therapies, I think that is where the field is headed.
That's great. And then clinical trials. I would
Yeah.
love to talk because I feel A lot of times consumers don't understand what clinical trials are today. I think for many of us, we think about in the past what clinical trials or have a preconceived definition of clinical trials. And so
Right.
I would love to hear from you. Are you seeing clinical trials in your practice, and how are you educating your patients about potentially raising their hand and participating in a clinical trial?
So it's a wonderful question, and I am something I'm very passionate about because I am a clinical trialist. So I'm not just seeing clinical trials. I am very fortunate to be part of some of those trials or helping design them. And I want to just demystify. There's different types of trials, and there's medical literature that shows that patients who are treated at centers where clinical trials are offered or who go on clinical trials are more likely to live longer in some cases than those who don't. And we don't know why exactly, other than perhaps, again, those patients are receiving more personalized treatment that's really taking into account what are the personal characteristics of this woman and her cancer, and how can we best treat it. And then, of course, you have subspecialists at those hospitals as well. But clinical trials absolutely save lives, and it's the only way we can learn how to advance the field and change standard of care. You can't just give patients experimental treatments without studying them. And we're doing them in a very safe and responsible way so that the trials now are very patient-centered. So it's very rare, for example, in a newly diagnosed patient with cancer, we will never put you on just experimental treatment that, if in other words, a treatment that we don't know if it's going to work. It's usually in the upfront setting when you're diagnosed that we're comparing standard of care plus standard of care with something else, or an alternative standard of care, so that a woman knows she's getting something that's going to work for her. We're just trying to decide, is there one that works slightly better than the other, for example. There are other types of trials like phase 1 and phase 2 trials that do offer more novel treatment opportunities. And sometimes they're kind of high risk, high reward situations, but we have to always put the patient at the center. And in fact, many patient advocates now help us design our trials. It's a requirement that we have the patient perspective within the trial. And so patients with cancer who've become advocates in clinical trials, or advocates on Capitol Hill, for example, help us really in the design of that. So we're always keeping in mind what's best for the patient.
Oh, that's so great to hear, and I love the positive spin on clinical trials because I do think it's so important, and from a healthy women lens, it's important for us to continue that education process so more people
Yeah.
raise their hand and participate. Um, I want to talk a little bit about prevention, and
Yeah.
especially, we're in December right now, but January is going to be here before we know it. And January is Cervical Cancer Awareness Month. So, prevention methods, you talked a little bit about it before, but let's reinforce what's the most important preventable thing that you can do to help prevent or diagnose early cervical cancer.
So, cervical cancer is almost entirely preventable. And that is because we have an amazing vaccine now that has been developed as one of the safest and most modern and effective vaccines that we're seeing tested in hundreds of thousands, if not millions, of patients across the country and across the world, that have shown that if you get the HPV vaccine, and the one most commonly used in the United States now is a vaccine against the 9 most common types of HPV that cause cancer in women or men, and also help prevent genital warts as well. So it's like that little bonus there. And what we're seeing from those trials were initially launched in the late 90s, early 2000s, and now we're seeing, 20 years later, that they are preventing dysplasia, they're preventing cancer, and they are life-saving, they're game-changing. I mean, imagine, like, we always are looking for that magic bullet, to cure
Yeah.
cancer. Well, cure cancer is great, but let's prevent it altogether. And it is very safe, very effective. We recommend giving it in boys and girls, pre-adolescent boys and girls, before there's any chance of them having a sexual encounter, because that's when it's going to be most effective, and the immune system of a child or a teenager is more robust. But you can receive the vaccination again from pre-adolescence to up to age 45. But I've also given it to women beyond 45 if I feel that they're at high risk or would benefit from it. And for parents out there, there's zero data that vaccinating kids increases their risk of having sex earlier. It is not true, and it's a very, very safe vaccine. So, and then Pap smears and HPV testing also have been game changers. So you might get a precancer, but we can head it off at the pass before you develop cancer. So these are almost entirely preventable cancers.
That's so great. And for all the women and men that are listening, annual wellness visits are so, so important, right? Because they're testing you from head to
Right.
toe, including reproductive. So you'll get your pap test, HPV. You could get your HPV vaccine. You can get your HPV test. Um, so important because we know preventative screening save lives.
Exactly. And then for endometrial cancer, again, another very preventable cancer in most cases, because upwards of 50 to 80% are obesity attributable or obesity associated. You know, and I'm someone who struggled with weight my whole life. A lot of women do, right? 2/3 of women are
That's right.
overweight in this
That's right.
country, and it is not anyone's fault.
No,
But it is important to think about the long-term effects of health, and so you know, healthy lifestyle modifications, even loss of 15 pounds, can really help reduce that risk of the obesity associated cancers like breast cancer, endometrial cancer, colon cancer. So really talking to your physicians about that is important, because most people associate obesity with diabetes and heart disease, which is
correct.
absolutely also a huge health issue. But cancer is, right about to overtake cardiovascular disease as the leading cause of death in women. And part of it, again, is because of this obesity epidemic. And so we as women, and as healthcare providers, working with community partners, working with public health agencies, really have to work hard to get a better handle on the obesity epidemic and thinking about how do we take care of ourselves, because we're always taking care of everybody else, right?
100%. 100%.
Our children, our spouses, our colleagues, our friends, and the patients we care for. And women are the matriarchs of the family. Like, they don't take care of themselves because they're so selfless and giving to others. But it's the new year almost, so we can make some New Year's resolutions here to go get your checkups, get prevention. And then final thing I wanted to say about prevention with ovarian cancer is, because we know that 90% of these cancers likely stem from the fallopian tube, we can now prevent many ovarian cancers by removing the fallopian tubes when a woman has completed childbearing, or when a patient is undergoing surgery for a different reason, like getting her gallbladder out, or appendix, or ovarian cyst, or whatever it may be. There is a lot of research happening now about, you can, through the small incisions, through that robotic or laparoscopic surgery, takes 10 extra minutes to take the tubes out, and the tubes don't generate any hormones, so women can keep their ovaries that produce the important hormones, reduce their risk of ovarian cancer and fallopian tube cancer, and reduce their risk of unwanted pregnancy. It's like a triple bonus there.
It's a trifecta right there. And
Yeah.
so let me ask, so just another quick question. When you were saying that, so patients that are undergoing tubal ligation, right? Would it be better just to take the two? Okay, I just have to say that because
Yes.
I'm in maternity, so my other
Yes.
hat is maternity.
Oh, that's wonderful.
So but I still see patients that are getting tubal ligations after they've made the decision not to have any more babies. But listening to our
Yes.
conversation today, I'm almost thinking, why not
And
just get rid of the tube?
that's exactly right. And it is the new standard now. If a woman no longer desires pregnancy and wants to get her tubes tied, really we should make tubes tying obsolete, because just remove it's not an organ that's helpful to a woman in any way by not having it. And the studies overall have shown that it doesn't cause major harm to patients in terms of earlier menopause and that sort of thing. Perhaps slightly earlier in a couple of studies, but in older women. And so in general, it's a really beneficial thing to consider doing if someone is having surgery, like a C-section,
Right.
for another reason, or wants to have permanent sterilization.
Oh my goodness. This has been an amazing conversation. And I'm telling you, if I lived in your area, you would be my doctor for
Oh,
sure. Like you, it's just that you're a delight. So
thank
I want to
you.
thank you so much, Dr. Fader, Amanda, for leading us through such an important conversation on gynecologic cancers. For more information on this topic, please visit healthywomen.org and tune in here for the next episode of Women Talk. Thank you.
Thanks for joining us for another episode of Women Talk. Stay tuned for more Healthy Women Live events at www.healthywomen.org. You can also follow us at Healthy Women on Facebook, Twitter, YouTube, or LinkedIn, or follow us on Instagram at healthywomen.org. We'll see you next time.